Anatomy video on YouTube. Today we're going to be focusing on knee anatomy. Presented by your host, Ken Knee. So we're going to be talking about the muscles of the knee, and we can talk about the motions that they can do. So a lot of the muscles of the knees are going to originate from the tibia or fibula, and they're going to insert themselves to the foot. So a lot of the movements are going to be at the ankle joint. So we're going to have dorsiflexion and plantar flexion. We're also going to have eversion, which is rotation towards the midline of the foot, and eversion, which is going to be rotation away from the midline. There are some exceptions to the muscles in the knee where they originate from the femur. In that case, those muscles specifically, they're going to be in the posterior compartment, and they're going to help out with knee flexion. So speaking of compartments, the knee is going to be divided into 3 compartments. We're going to have the anterior compartment, the lateral compartment, and the posterior compartment. And the posterior compartment is going to be further divided into 2 more compartments, which is going to be the superficial and deep compartment. So let's start off with the anterior compartment. The anterior compartment is going to be anterior to the interosseous membrane, or for our international students in the UK, our interosseous membrane. And their function is going to be dorsiflexion of the ankle, extension of the toe, and depending on the muscle, eversion or eversion. Inversion or eversion. So a way I like to think about dorsiflexion is, if you think of dorsal, think of a dorsal fin, and you see shark fins pointing up. So your toes are going to be pointing up, and there's going to be more pressure on the heel of your foot. So let's start off with tibialis anterior. So tibialis anterior is going to be one of the most superficial anterior muscles, and is going to be the most medial. It is going to originate from the lateral condyle to the upper half of the lateral surface of the tibia. So right here we have the tibia. So the lateral condyle is going to be right here, and this is going to be the lateral surface of the tibia. Thus, this is going to be the origin site for tibialis anterior, and it's going to insert itself in the medial cuneiform and the base of the first metatarsal bone. Right here, we're going to have medial cuneiform, intermediate cuneiform, and lateral cuneiform. We're also going to have the navicular bone and cuboidal bone. We'll go over this more in the feet anatomy stuff. Right here, this is the base of the first metatarsal bone, and that's going to be the insertion site of the tibialis anterior. So you see that arrow is pointing upward, but muscle pulls the insertion site to the origin site. So with this, the main function of the tibialis anterior is going to be dorsiflexion and inversion. And it's going to work synergistically with tibialis posterior for inversion. And another fun fact is going to be that tibialis anterior is going to be the strongest dorsiflexor of the foot. Next, we're going to have extensor digitorum longus, which is going to be the most lateral anterior muscle. So who do we think it is? This one. And this is going to originate from the lateral tibia condyle to the superior 3/4 medial surface of the fibula. So right here, lateral condyle of the tibia and superior 2/3 of medial surface of the fibula. And it's going to insert itself in the middle and distal phalanges of the lateral 4 digits. So the big toe is the first digit, and the rest are 2, 3, and 4, 5. They're the lateral ones. And this is going to help extend, pull upwards toes 2 through 5. Next, we're going to talk about extensor hallucis longus, which is going to be one of the deeper anterior muscle, but it will be superficial down in the distal portion of the leg, right here. And that is going to originate in the middle part of the anterior fibula. So right here. Let me fade others. Bam. And this is going to help with extension of the great toe and dorsiflexion. Lastly, we're going to have fibularis tertius, which is going to originate from the distal half of the medial fibula, and it's going to insert itself in the dorsum base of the fifth metatarsal bone. And this is going to have weak dorsiflexion and eversion. And I believe this muscle is often not present in a person. This is just a textbook muscle, you know. And I believe our model in VH dissector does not have this muscle. So once again, the tibialis anterior muscle is innervated by the deep fibular nerve and is a branch of the common fibular nerve. And this is going to run anteriorly with the anterior tibial artery. And that's going to supply blood to all the anterior muscles. And the anterior tibial artery is a branch of the popliteal artery. And it passes through the interosseous membrane and descends with the deep fibular nerve. So the role that the anterior compartment has in gait or our walk cycle is that dorsiflexion keeps the toe up during our swing phase. And tibialis anterior eccentrically controls foot lowering. In other words, that this muscle when we're walking, we're gonna first hit the ground with our heel. And our foot would have a tendency to kind of just slap the ground. But with the tibialis anterior, it's gonna slowly release its tension to decelerate the foot when it hits the ground, so we're not slapping the ground. And let's say if we're swinging or kind of swaying backwards, so kind of like this. Let me pick a different color. Kind of like this. The anterior compartment is going to offer stability and keep balance. Also, if you ever dig in with your heel, that's going to be the anterior compartment because of dorsiflexion. So some clinical correlation is, let me try to highlight the nerve. If you're wearing tight boots or tight ski boot, it might compress on the deep fibular nerve, and that is going to be deep fibular nerve entrapment or ski boot syndrome. With this, there's going to be compression, and it's kind of going to leave pain to the anterior portion of the leg, and there's going to be pain associated with dorsiflexion. Another clinical correlation will be, let's say if you're running and you're just an untrained athlete, You're going to experience some shin splints, which is going to be tibialis anterior strain. And it's just going to be pain here because we're using this muscle over and over again and it's not used to it. So there's just going to be a pain associated with dorsiflexion. Next, we're going to talk about the lateral compartment of the leg. This is going to be our smallest compartment. And it's mainly going to help with eversion and assist in plantar flexion. With plantar flexion, I like to think of it as you're planting your toes into the ground. So you're planting your toes into the ground. So to remember, like, your toes are going anywhere and your heel is going up. So it's going to assist with eversion at the subalter joint, which is going to be right here. Eversion. And at the transverse tarsal joint. The lateral compartment is going to be innervated by the superficial fibular nerve, and it's going to have blood supply from perforating branches of the fibular and anterior tibial arteries. So we're going to first start off with fibularis longus. So guess which muscle is that one? Correct, it's that long muscle. And it is going to originate from the head and the superior 2/3 of the lateral fibula. So right here, this is going to be the origin site for fibularis longus. And it's going to insert itself at the base of the first tarsal bone and the medial cuneiform. So right here, you see how it kind of crosses over? It's going to attach itself right here and here. Also, a quick little mentioning of the foot bones. We have the medial cuneiform, intermediate, lateral, cuboidal, and navicular. So this is going to cross over here, and this is going to help with eversion. And it's going to weakly help with plantar flexion. It's going to be the more superficial muscle in the lateral compartment. And let's say if you're standing on one leg, it's going to provide some tension to kind of help balance yourself. Fibularis brevis is going to be in the lower third of the lateral fibula, and it's going to attach itself to the tuberosity of the fifth metatarsal bone. So right here, here's the lateral tibia and the lower third. Here's the origin site, and it's going to attach itself to the tuberosity of the fifth metatarsal bone right here. And this is going to help with eversion and weakly with plantar flexion. Brevis is going to be a little bit more, it's going to be more deeper in the lateral compartment. So the role of the lateral compartment is to depress the medial margin of the foot during the push-off phase. And it's going to help stabilize the ankle when running and walking to just prevent inversion injuries. And like I mentioned before, if you're standing on one leg, fibularis longus is going to help give you balance. So you don't fall sideways, you know? So your body would be like this. It's just going to provide some tension here to kind of keep you grounded. Some common injury is going to be superficial fibular nerve entrapment. So let's say you keep on having these ankle sprain, it's going to stretch out the nerve. So there's just going to be some numbness to the lateral portion of your leg. And now that we are talking about the superficial fibular nerve, we can talk about the common fibular nerve, which is going to be right up here. Hold up. The common fibular nerve is going to wrap itself around the neck of the fibula. And this is going to be the most commonly injured limb nerve. It's vulnerable to direct trauma, fractures, knee dislocation. And the moment that this is injured, we're going to have paralysis of the lateral and anterior compartments. So remember, the lateral compartment helps a lot with aversion, and the anterior compartment helps out a lot with dorsiflexion. So when this happens, we're gonna kind of have like a foot drop. Let me go back to our skeleton. So with injury to the common fibula, our foot won't be able to dorsiflex anymore. So we'll kind of be like this. And it won't be able to evert anymore. So it's going to be more like that. So this is going to be really hard to walk with. So that's why people with this, they're going to have a high step. So there's going to be an exaggerated hip flexion and an exaggerated knee flexion to kind of make up for the drop foot. And they're going to kind of have a more outward walk like that. And whenever they hit the ground, their foot is basically just going to slap it. And now we're going to go to the next compartment, the posterior compartment of the leg. We're going to start off with the superficial compartment. So the superficial compartment is going to be it's going to be part of the posterior compartment. And this is going to be the largest leg compartment. It is going to help a lot with plantar flexion. So remember, planting your toes in. It's going to help out a lot with toe flexions. And it's where the tibialis posterior is, and it's going to work synergistically with the tibialis anterior for inversion. So plantar flexion is really important for just basically the push-off phase for walking. It kind of thrusts the toes up. And the posterior portion of the leg is going to help maintain balance and posture while we're standing. The nerve that's going to innervate the posterior section of the leg is going to be the tibia nerve, and this is the same for the deep posterior compartment. And the arteries is going to be the posterior tibial artery, and that's going to be a branch from the fibular artery. So now let's get started with the muscles. These three muscles are kind of collectively known as the triceps array, and it's going to be our gastrocnemius, soleus, and plantaris. So let's start off with the gastrocnemius. We're going to have a lateral and medial head. Medial and lateral head, my bad. The medial head is going to attach itself to the medial condyle of the femur, and is also going to originate kind of a little bit in that popliteal fossa. Then we have the lateral gastrocnemius, which is going to originate from the lateral condyle. And the gastrocnemius and soleus are going to insert themselves to the calcaneal tendon, which is our Achilles tendon. And this muscle is going to help out with plantar flexion when the knee is extended. So the moment it's flexed, it's not going to help out. And this muscle, since it originates in the femur, it's going to have some action in the knee joint. So it's going to help out with knee flexion as well. Another thing I would like to mention is before it becomes part of the calcaneal tendon, there is that little peak section right there that I highlighted, and that is going to be our gastrocnemius musculotendinosus or tendinous junction. So right below the gastrocnemius, we are going to have our soleus, which is going to be a very flat muscle. It is going to originate from the posterior surface of the fibular head right here. And the soleal line, that pink line right there, bam. These are going to be the origin sites for the soleus. And they are also going to insert themselves in the calcaneal tendon. And this is going to help out with plantar flexion. And it's independent to the knee. Unlike the gastrocnemius, which can only do plantar flexion when the knee is extended, the soleus does it when it's flexed or extended. So this is going to offer more like posture stability. Lastly, we're going to have the plantaris muscle. And this is kind of a vestigial muscle. 5 to 10% of people don't have this muscle. And it's going to attach itself to the lateral supracondyle line right here. And it's going to insert itself pretty close to the calcaneal tendon. Just a little bit off to the side right there. Oh yeah, this is the calcaneal tendon, Achilles tendon. And this is the calcaneus bone that it's attaching to. So just a refresher, the soleus and the gastrocnemius both had come together to form the calcaneal tendon, and it is going to insert itself to the posterior surface of the calcaneus. So going back to plantaris, this helps weakly with plantar flexion. There could be some knee flexion since it originates from the femur. Possible proprioception as well. So this muscle, a lot of people confuse that long skinny tendon for a nerve sometimes. It's kind of called a freshman nerve, but it's not a nerve. It just gets mistaken for that. The calcaneal tendon is one of the strongest tendons. It is the strongest tendon in the body. And if we look at a clinical correlation, let's look. We can have some tibia nerve injury, and with a tibia nerve injury, the tibia nerve is pretty deep in the muscle right here. So it has to be like something drastic to have caused an injury, like a deep laceration or like a posterior knee dislocation, and it's just going to cause like paralysis of the posterior leg muscles. And so there won't be plantar flexion. There will be a loss of plantar flexion, and there won't be like that push off in our gait. Another clinical correlation will be ruptured Achilles tendons. And that is usually caused from a very forceful plantar flexion. And it would happen most commonly in middle-aged individuals. And you would just have loss of plantar flexion. Now we're going to move on to the deep posterior compartment of the leg. And they're going to be 4 muscles. These are all innervated like the other ones from the tibial nerve. And they're going to help out with plantar flexion, but it's not going to be as much. The superficial compartment does most of the plantar flexion, like 90%. And this does around like 7%. So the superficial does like 93%. So we're going to start off with this thin triangular muscle, which is going to be the popliteus. And it is going to originate from the lateral femoral condyle and insert itself to the posterior tibia, bam, right above like the soleal line. And it's going to kind of unlock the knee to lateral rotation when the knee is flexed. Secondly, we're going to have flexor hallucis longus, which is going to be this lateral muscle. This is going to originate from the distal 2/3 of the posterior fibula. Right here. And it's going to insert itself at the distal phalanx of the great toe, right here. And this is going to help the flex the big toe, and it's going to weakly help with plantar flexion. Next, we'll have the flexor digitorum longus, which is going to be more medial. And this is going to originate from the posterior tibia. Right here, right here. Inferior to the soleal line. And it's going to insert itself to the distal phalanges of the lateral 4 digits. And it's going to help flex toes, the lateral toes. Right here. Bam. And it's going to cross over. Bam. And lastly, we have tibialis posterior. And this is going to be the most deep posterior muscle. It is going to originate from the lateral surface of the posterior tibia. And fibula, I believe right here. Yes. And it is going to insert itself to the navicular bone and the cuneiform bones, cuboidal. It's a lot of bones. Let me remove this one. Hi. So right here, the cuneiform bones, lateral, medial, intermediate, and medial. The navicular bone, and the base of the metatarsal 2 through 4. And it's going to help out with plantar flexion, inversion synergistically with tibialis anterior, and it's going to support that medial arc. It's going to be a key arc stabilizer. So that is it with the muscle in complete anatomy. We have the tibialis posterior, flexor hallucis longus, popliteus muscle, and flexor digitorum longus. So we can go over to VHI sector just to kind of make sure we know everything. Jump scare, guys. I did not know everything on VHI sector. That footage, a chop. It was, a lot of mistakes were made and a lot of the muscles were absent or vestigial. So it was, the lines were blurred for some of the muscles, and I'll make another one, but maybe closer to the practical if that's what you guys would like. So yeah, please give this video a thumbs up and subscribe to the Complete Ken Nation. We need more people. Right now it's sitting at a current 0, but that's okay. So yeah, if you guys like the video, please let me know and I will continue to make more. So that's it. Good luck studying, y'all.